Hello, welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am joined by Dr. Martha Carvour, who is the assistant professor of internal medicine and infectious disease at the University of Iowa in Iowa City. Thank you so much for joining us. How are you today?
I'm great. Thank you so much, Dr. Fleming. It's great to be here.
And so, how is Iowa treating you? I hear there's snow.
Yes, we've had some snow starting to fall just again today, so not too bad, all things considered.
Well, it is that time of year. It's that time of year.
Yes, it is.
So I thought, we are kind of in the midst of our next COVID surge, and you have a unique position as, both an internal medicine doctor and infectious disease trained doctor, and you have a unique Ph.D. that I thought you'd like to share a little bit more about, and as opposed to me trying to tell people what it is.
Sure, yeah, and I'd be happy to. I do have a PhD in epidemiology, and that actually came about a number of years back. I had known that I wanted to do science, that I had wanted to become a researcher as well as a physician. And I thought a bit about different pathways that I could take. And the thing that really stood out to me at that time was the idea of population health science and thinking about our ability to provide care and also just to do rigorous studies about population health, about epidemics, even pandemics as we're seeing now, and thinking about the ways that we can approach infectious disease problems and other types of medical conditions and public health problems, thinking about it from a population perspective and thinking about the health systems and the public health systems in which these things happen. So that was a really exciting point of interest for me back then, and I've stayed engaged in epidemiological research. Certainly didn't anticipate that the last year would look exactly the way that it has, but it's been a really interesting perspective to kind of bring all of those different pieces to the work that we've been doing.
And so, being in Iowa, kind of middle America, and most of Iowa is more rural than urban, right? And so I know that brings a unique set of challenges to the practice of medicine and infectious disease, and as it relates to COVID as well. But can you speak a little bit more about what you've been, or any recent projects around health equity in rural America that you've been working on?
Yeah, absolutely. We have several unique challenges, as you mentioned, in terms of rural and frontier counties across the US, and certainly Iowa has a number of rural counties. And there are significant differences in sort of access to care or distance to care for different types of healthcare. And that affects a lot of our rural or rurally based patients, as well as rurally based healthcare providers who may have less access to resources or fewer access to resources to refer patients for specialized care. So that's been an area of interest for us here. And one of the things that we started out doing actually with Dr. Del Castillo, who's a part of the Read Scholars program, is part of our research team and working on this, is studying the experience for COVID infections and COVID-related mortality in rural America. So looking at counties across the United States, in Iowa and in all of the other states where there are rural counties, that looking for disparities in the rates and noticing what might explain those disparities. And we have noticed significant disparities, again, by race and ethnicity for rural as well as metropolitan areas. And that's one of the things that we've been working on in our research project, understanding what are the structural and systematic bases for those inequities.
Yeah, I'll be interested to see what you all find. I think, we talk about social determinants of health and the definitions of them, but how they actually interplay in different parts of the country is different, right? And usually I use the example of transportation. We talk about access to transportation in an urban area is a very different set of barriers when you talk about access to transportation in a rural setting, right? Because of things like geographical distance and just transportation period, not whether you have, whether you have it or not. Not necessarily how good it is and how well you can assess it. So, the nuances are great, but are still very important in different parts of the world. So kind of transitioning just a bit. So in thinking about rural America, and thinking about COVID, like I think earlier in the as the pandemic was evolving, thinking about those geographical differences, a lot of people were assuming, well, if you're spaced further apart, there's less population density, um, less transportation to that, or less transit to that area, I should say, not less transportation, less foot traffic to the area, that was going to be protective over a long period of time. And I think we've seen that that's not necessarily the case, and things have shifted, right? So tell us a little bit about what you're seeing there as it relates to COVID, and your concerns or your worries about that patient population.
Yeah, that's a really good point. So I think we often think about the rural counties as being so much more spread out in terms of population, and think of that perhaps as protective. And it certainly is true that if someone is working in a relatively isolated environment and not coming into direct contact with as many people, and that's the type of work that they do in the rural environment where they live, then that's possibly protective. But it's certainly true that in rural counties and in rural towns and communities, people still spend a lot of time in small groups and communities, maybe in either in organizations within their community, possibly religious services, possibly at work. One of the things that we've also seen highlighted in this particular pandemic throughout the US and here, right here in the Midwest as well, there are meat packing plants and other agricultural facilities where individuals who may live in predominantly rural environments are working in very close quarters and potentially at risk for contracting the infection. So those are certainly concerns. And as you mentioned, I think thinking about access to testing or access to care, and thinking about just making sure that the messages around prevention and treatment are extended into rural counties as well, and certainly into those occupational settings where risk may be particularly high.
And I think that's what a lot of the studies are showing, that a lot of transmission is actually coming from these small, not big crowds, which they have their problems too, but these small groups of people in what we would consider safe settings. And I would postulate, I mean, this is me guessing, but I'm also thinking because there might be this feeling of protectiveness or safety, that if once things enter in the community, it spreads even quicker, right? Because you're not thinking that, oh, I need to protect myself. It's the same group of people that I always hang out with. But if one person becomes exposed, we know that because of the highly contagious nature of the virus, it spreads. So the other question, I think that's interesting, we talk about access in different parts of the country, and transitioning to talking a little bit more about the vaccine, right? So we've noticed that we have two vaccines that are readily available, and we have a lot of people who've been vaccinated so far, but not at the rate in which I think people thought the uptake would be. So I guess I'll let you talk a little bit about, you can have any general comments about that if you want, but also thinking about distribution and access. When you're thinking, you look at your California numbers and your New York numbers, which of course have large populations, so they get access to a lot of things, but worrying about if places in these smaller rural states are getting the same access and to the vaccine as we think they should.
Yeah, that's a really interesting question. I think there are a couple of different ways of thinking about it. I think it is certainly possible in some more rural environments to think about having well-situated vaccination programs where you can try to get through a large proportion of eligible patients and vaccinate a large proportion of eligible patients in a single few days span of time. And so I think that's helpful from a practical perspective. That's sort of counterbalanced against some of the other logistical challenges with the vaccines, thinking about storage requirements, transportation requirements, and the needing to expend a certain number of doses from a vial. And we sort of hear about different stories related to that from a number of different vaccination programs. And those are also things that just need to be considered in planning those types of rollouts in more rural environments.
So, there's also a lot of discussion around the vaccine and whether or not to trust it or not, right? And so in any, I think, health equity conversation around the vaccine right now, is who's taking it and who's not, and who's refusing it and who's not. Um, what are your thoughts about encouraging people who have often been marginalized in the medical system, in clinical trials and the like, about why should we trust? We keep saying trust the science, but why should we trust the science? A little bit about the process of how vaccines come to be, and why that makes them trustworthy.
Yeah, I think that we do know that the vaccine is effective. In fact, both of the vaccines that are currently in distribution or in use more widely in the United States, that these are effective. The trust issue is a very significant one, and I think first and foremost, I would say that the mistrust and the experience of marginalization and minoritization within the healthcare system. This is based on very valid and very recent experiences, even in terms of the COVID pandemic. I know we talk about historical injustices, and those are absolutely real. The Tuskegee experiments, for example, I know this is often raised as one of the major issues that we think about, or the major stories that we think about. But I think I would be remiss as a physician and as an epidemiologist to say that we don't still have a lot of injustice in our healthcare system and in the way that science is translated eventually into practice. So I think we need to start with that sort of truth telling, I think, to talk about where there is mistrust and what the system and its healthcare providers and scientists also need to do to restore that trust. And in the process, I also think it is important to make sure that we communicate about the vaccine, and that we do ensure that patients and populations and communities who have historically been marginalized or minoritized in the healthcare system or the public health system have access and quick and ready access to the vaccination. In this case, and I know that others have kind of made similar parallels, if we were not to vaccinate historically minoritized communities at the same rate as perhaps other communities that are more closely engaged or more well represented or more inclusively represented, the inequities would get worse. The inequities in COVID would get worse. So we do have an important place to start here in ensuring that we provide accurate, helpful information about the vaccine, that it is safe, that it is effective, and that it has gone through rigorous testing already in order to even be at the place where it is approved for emergency use under the Food and Drug Administration. There are still studies that are ongoing, and I think it's also important for healthcare providers and scientists to continue to ensure that we have equitable and inclusive clinical research around COVID and equitable inclusive monitoring for patients who perhaps had COVID or who have been exposed. So I do think that there are at least a couple of different approaches that need to be taken. One of the most urgent is getting vaccinations rolled out so that we can protect as many people as equitably as possible. But that doesn't erase the fact that there are a lot of very serious health equity issues that really need to be addressed. And I'm hopeful that this pandemic and that some of the issues that it's continued to highlight will be an impetus for bringing about more of that change.
Yes, we talk a lot, and we've talked a lot on this particular podcast over the past year about kind of the unearthing to the, well, we should say more of the population and to the rest of the world around health disparities in general, but inequities, period, across the board, even outside of health. And, we can go down that road of all the things that happened in 2020 and are still happening in 2021. But, I'm optimistic with you that hopefully now that we are talking about it a little bit more openly, that we can continue to do the work to change it. So we are definitely tracking in the same direction there. And just to do a little bit of the nitty gritty stuff, because, these are the questions that we get asked often. about the vaccine and getting the vaccine. And since you are an infectious disease specialist, I figure, you will offer some more legitimacy to these answers than me. But, the questions that I often get are, what's the difference between the Pfizer and Moderna vaccine? There are two doses. Why do you need both doses, and what does that mean? And then, what can we expect, if anything, kind of going forward after we take the vaccine in mass, hopefully, crossing our fingers, right?
Yeah. Yeah. Those are definitely some of the most important questions that we hear over and over again. I think to the first question, the Pfizer and Moderna vaccines are very similar. I think of them as basically being interchangeable. They use very similar approaches and are very similar in terms of their effectiveness, their side effect profiles, and so forth. Even when we think about vaccines for healthcare workers, it really is sort of which one is available for distribution on a particular day when we're undergoing a vaccination effort. So there isn't one that's clearly viewed as superior to the other. So we're working on getting vaccines for one or the other for right now. In terms of the 2-dose question, that's a really important one for these vaccines. It does look like it's that second dose that really enhances the effectiveness of the vaccine. So you probably will get some help from the first dose, but that second dose really does seem to make a huge difference. And so you will be getting the most out of the vaccine if you do in fact get both of those doses about 3 weeks apart or so. I think it's important in thinking about those 2 doses to reinforce that no one should expect to be immune from the virus after the first dose, and that it can take a while for the body to mount an immune response. Right. And so we have heard these reports of people who maybe got the vaccine and then got the infection, a few days later. It's likely that the vaccine hadn't had a chance to be effective yet. So it does take a while. It takes a little while for the immune system to become active enough to create antibodies to protect us against that infection. So getting both of those doses and continuing to maintain things like mask use, hand washing, social distancing. Exactly. For ourselves, for those who might have been vaccinated who are around us, those are still critically important things to keep in mind. And those, as we're seeing, and I'm hopeful that we'll continue to see, those measures, hand washing, social distancing, mask use, that should help to reduce other types of infections in the winter as well. So things like flu and other common colds. And so there are lots of good reasons, especially right now, to be practicing those things, even while we're waiting for the vaccine to be rolled out and for the vaccines to have their full effect. We're certainly hopeful that as we have more and more people and more populations across the US getting vaccinated and getting through hopefully that full 2-dose series, that we will see the infection rate start to decline. There is a lot, as has been true for the last year, there's a lot that's sort of unknown, that we need to kind of watch and wait and see what happens. So I would personally be reluctant to, think about stopping mask use at any time in the near future. It's still going to be important on a population level, even if we're protected individually with the vaccine, to make sure that we're getting where we need to go as a whole community, as a whole population, in terms of the number of infections happening, the number of people who are perhaps being hospitalized with COVID. So long term, I think certainly the goal is that we will have enough immunity in the population that we can get back to somewhat more normalized daily activities. But I would not go so far as to put sort of a timeline on that or a specific expectation at this stage. And I think this is a somewhat personal opinion, but I think sometimes it's more helpful to be clear about what we don't know instead of putting too early a deadline on something or pretending or imagining that it can happen sooner than it will. And I think in some ways that's been frustrating over the past year. I know there have been times when many of us heard messages that if we did this for this period of time that somehow things would be okay. And it's true that it takes a long time to address a pandemic of this scale. So continuing to find those ways to protect ourselves in the meantime, and continuing to think about protecting ourselves in other ways. So other healthcare conditions that need care, thinking about things like mental health and talking to a therapist or talking to, community members and family and friends, even if we're doing it using technology that's available. It's really important to be thinking about our overall well-being and wellness throughout this time, because it is likely to still be a long process.
Yes, definitely. Thank you for bringing, that last point up. I think we are spending a lot of time focusing on COVID and the pandemic, which is important, but we shouldn't do that at the expense of letting these other conditions either not go well treated, or new things that are popping up, which, our mental health challenges are especially troubling during a pandemic, and the social isolation, and, just dealing with, the loss of family members or the sickness of family members can be a lot. So definitely, we encourage you all to take care of yourselves completely as whole human beings, and not solely focus on the COVID pandemic. Well, as we draw to a close, I usually like to hear from you what you're looking forward to kind of once we get through this, either professionally or personally. Kind of what are you looking forward to on the other side?
Yeah, I think personally, this may sound simple, but sometimes it's the simple things that we miss the most. I think when things start to normalize a bit more, just being able to go out to a coffee shop and sit down and have a normal coffee with a friend or colleague, just being able to have that sort of normal experience and see other people around, and kind of get back to that. And I think professionally, I'm really interested to see what happens as we continue to talk about and really think deeply and critically about what we've learned from the pandemic, not only in terms of infectious diseases and even infectious disease epidemiology, but about the way that our healthcare system works, about the way that our public health system is kind of put together or constructed, what worked, what didn't. I think for myself as an epidemiologist, for someone who's really focused on thinking about the way that systems work and the way that we can ensure equity in healthcare and public health, this is a really important time, I think, to speak up, to be talking, to be having those conversations, as you mentioned, and to use this as a really good opportunity to say, how do we do better? How do we think about the system? How do we kind of change that? And I think historically, it's true in many systems that it's very hard to change. We're always a little bit resistant to change. And yet the healthcare system has been forced to change in so many ways over the last year, that in some ways I look forward to having those conversations to push back on that a little bit and say, the system can change when it has to. And so what do we need to do to make clear that this is something else that must happen, and that it must happen quickly and as a priority.
Definitely. It has taught us that we can change, and we can change quickly when forced. So hopefully some of that will continue on, and we will learn a lot and be better for it in the future. So, well, thank you so much. I appreciate all your insights and sharing with us about your journey and your recommendations going forward. So we really appreciate your time today.
Yeah, thank you so much. It was great to be here.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.